Close to Home, a personal look at the opioid epidemic in Iowa.
United Community Services, over 20 years ago, we focused on substance use disorder treatment, including medication-assisted treatment. And then in 2012, we started adding on programming such as mental health and psychiatry, and then also family practice services. That way we can really meet the patient's needs in any area of healthcare that they need. You can get your primary care provider here at UCS Healthcare, or you can come in for addiction medications, mental health, so on. So at UCS Healthcare, we do serve a lot of different demographics and a diverse population of patients. And one of those populations is LGBTQ. And we do have physicians that have built really great rapport with the patients, are very educated in LGBTQ needs in healthcare, and really the whole agency creates a welcoming environment for this population to get all of their healthcare needs served. So just plain physicals, or if they're interested in doing PrEP or hormone replacement therapy, there's always a safe and welcoming environment where people can come in and get their healthcare needs met. So over the last 20 years, UCS Healthcare has been treating patients with opioid use disorder with medication-assisted treatment. And so that's something that we've been really involved in and are really experienced with in treating these patients. Now, when the opioid epidemic came out, a lot of other providers around the state of Iowa didn't really see as much need as we knew there was out there. And so we started having conversations with other agencies in Iowa to talk about how we can bring medication-assisted treatment to their facilities. That way patients in those communities can have access to medication-assisted treatment for opioid use disorder. At UCS Healthcare, we were seeing patients drive 2 to 3 hours one way just to receive medication-assisted treatment at our facility in Des Moines. And so we knew that there were patients out there in different communities around Iowa that really needed better access to that type of care. And so now that we've been able to embed medication units into treatment facilities, we are able to offer medication-assisted treatment for opioid use disorder. And then the agency that's hosting us is giving the therapy to those patients. And so they're accessing care that's data has shown to be really beneficial in treating opioid use disorder. UCS Healthcare's future includes a lot of new programming. We are looking to add peer support services, a very robust programming around peer support in both addictions and mental health services. And then we're also doing some support groups for the community. So not just patients of UCS Healthcare, but people that might be in the community that want education about different types of treatment that we offer here at UCS, and just to have a support group and a community of those populations that people are trying to connect with. So we have support groups for transgender populations and gender nonconforming. We have that in adult and also in adolescent. And then we also offer family groups and other educational groups for family and concerned persons. The other piece of the future for UCS Healthcare is that we are rapidly expanding, and we're going to be adding this new programming. We're constantly seeing our patient population increase, so we are going to be moving to a larger location in West Des Moines. That should give us an opportunity to offer even more programming around the needs of our patients that we see, and also community needs. And then lastly, I would say that because we are really focused on patient need, we also need to be an employer of choice and really bring in the people that are passionate about the work that we do at UCS Healthcare and get the right staff members to work with these populations of people that we work with on a daily basis. And by doing that, we can offer some benefits packages that are really robust, like a large portion of the medical benefit is paid. We offer tuition reimbursement. We offer a retirement match benefit and a robust PTO package as well.
So if we're looking at the effectiveness or the benefit to medication-assisted treatment, there's really no parallel. If you look at an individual that just goes into a hospital and receives detoxification for an opioid use disorder, the effectiveness of that long-term is about 2 to 3%. If you look at just traditional treatment, so just the counseling, talking with an individual that has an opioid use disorder, that can be anywhere from 10 to 30% effective. When you add medication-assisted treatment, those numbers increase to about 60 to 80% effective. It's probably not proper terminology, but it's a no-brainer. I mean, medication-assisted treatment works. It is the gold standard for providing services for individuals with an opioid use disorder.
There are about 3 different medicines we use for opiate addiction. When I first started, methadone was the drug of choice, and we use methadone primarily for most of our patients still. And in order for it to be effective for treatment, what we have to do is slowly titrate that medication up to the point where the patient's withdrawal symptoms are taken care of, where their cravings are taken care of, but at the same time they're not feeling euphoria, they're not getting high. Initially, they will come into the clinic and we will interview the patient, decide how long they've been on the medication, what amount they're using on the street, or that they're getting from a provider, and try to set up a treatment plan that would help them get off the medication in a reasonable amount of time. However, I think a lot of people have some very unrealistic expectations about how long that takes. SAMHSA, which is Substance Abuse and Mental Health Services Administration, which oversees methadone and buprenorphine, actually recommends that if you use MAT treatment less than a year, there's almost an 80% relapse rate. So it's very important that we continue this for about a year. They have to come to a clinic every day and get their dose and then leave. We have, at UCS Healthcare, have decided that we would expand our hours. Most clinics initially, I remember we started out from 6 in the morning or 5 in the morning till about 11 o'clock, which for people that worked, second shift or third shift, it became very difficult for them to come in and actually get their dose and leave, unless they had take-homes. So we expanded our hours. We have from 6 in the morning till 5 in the afternoon. And patients can come anytime during their lunch hour or after work or before work to try to get their dose taken that day. The amount of time that it takes for that molecule to go away is almost 72 hours. So it lasts a very long time. And the advantage of, since it's bound to the receptor, nothing else can get in there. So if you tried to use something like hydrocodone or heroin or something else, it blocks it. So it's not able to come in and actually do anything to it, and you're wasted your time and your money. If somebody lives in Burlington, for example, and they were on methadone, it's a really large burden for them to come up here and be seen every day. So the advantage of the buprenorphine is because it's a little different molecule, it's not as controlled by the federal government as the original product, the methadone, was. So actually, I can prescribe it in a prescription to that patient, and they can get it at their local pharmacy. One of the things people ask about is whether one drug works better than the other. And both are equally effective for patients, and really depends on the patient and their own metabolism, what works. One of the questions I get a lot of times is, well, you're just substituting one drug for another. What we're really talking about here is harm reduction. And in the long run, what happens is, yeah, I'm putting one drug in place of another, and that's what I'm doing. But at the same time, that patient is under a doctor's care. They're not out on the streets looking for the drug. They're not committing crimes that would put them back into jail. They would not have any problems as far as medical care because they're seeing a physician regularly. They're able to hold a job. They're able to pay taxes. They're able to be with their family, reestablish relationships. So truly, where's the harm in this activity? We're really trying to help these patients get back to their normal lives. One of the things that we've also found is that if we use just the drug alone, there's almost a 30% chance that we're going to get a good result over time. However, if we combine counseling, group therapy, and having that relationship with the patient, we're actually able to see figures up into 80% effectiveness range. So what we're trying to do is provide people opportunities to learn how to deal with their triggers, learn how to deal with other people, being able to have other people to talk to about what's going on in their lives and how they can deal with that in a better way than what they have, because obviously what they've been doing for a long time has not worked for them. One of the things, though, about addiction is every day you have to think about what's going on, and it's a lifelong disease. We know that people inherit the disease. It's genetically transferred from a lot of people. Not everyone, but there's a tendency, and it runs in families, where addiction becomes a lifelong process. And really we need to look at the disease model of addiction. And one of the things we also think about when we use MAT therapy, we're using a medication to treat a disease. Medication-assisted treatment actually means using medications in conjunction with therapies, counseling, and all that psychosocial support to be able to come and develop that person fully and have them come back to being a whole person.